This topic is encopresis. Encopresis is the repetitive, involuntary or voluntary passage of stool in inappropriate settings. Encopresis is specific to this age group of 4 and older because children of this age are expected to have gained bowel control and toilet training. As you can see in the illustration to the right, constipation plays a large role in encopresis, and we'll talk about this in more detail in later slides. Encopresis can be broken down into 2 categories, primary and secondary. Primary encopresis involves children who have never obtained bowel control or toilet training, and this may be due to an underlying medical condition or even developmental delays. Secondary encopresis is in children who have already obtained bowel control, but for some reason, they are now having accidents again. Secondary encopresis is also known as functional fecal incontinence. And this can actually be broken down even further to 2 subcategories, non-retentive and retentive. Non-retentive just means there's no history of constipation. Retentive, if you think about retaining, it means withholding. That means the child does have a history of constipation. Retentive secondary encopresis is common in children who are going through a large life event due to the emotional stress. So this could include moving schools, moving states, or even a divorce. Children who have actually experienced a painful bowel movement in the past may anticipate this and actually withhold their stool, hence the retentive encopresis. This is due to their anticipation of the pain and they don't want to experience it while passing a bowel movement. Here's an illustration that depicts retentive type of encopresis. On the left-hand side, you can see stool moving freely through the bowels. As you can see on the right-hand side, there's a large stool burden in the rectal vault and the sigmoid colon. The longer the stool stays in this area, the more water it will lose and the harder it will become. This can actually lead to a fecal impaction. Now, when it comes to functional fecal incontinence, what happens is the client will continue to produce stool. This stool has more fluid or water content and will be softer. This soft, freshly produced stool will leak around the hardened stool, and that's where we see this fecal incontinence. Clinical features of encopresis include episodes of involuntary daytime or nighttime defecation. The client may experience abdominal pain or even distension. The stomach is going to grow with the larger stool burden and try to accommodate that. Painful bowel movements will be a part of this process. Again, this large stool burden will continue to harden the longer it's there. Once the client is actually able to pass this bowel movement, it may present as hard balls or pellet-like stools. It's important to remember that having accidents can actually have psychosocial implications. Remember, these clients are around school age, so they may be having these accidents in front of their friends, peers, or classmates. That can cause them to be embarrassed, have feelings of guilt, and even low self-esteem. This can eventually lead to them self-isolating, and we really want to make sure that we're monitoring this. When it comes to nursing interventions for encopresis, we just need to treat the underlying condition causing it. So if constipation is causing the encopresis, the client may need to take stool softeners. An example of a stool softener is Docusate. This will help bring water content into that hardened stool, soften it, and allow them to pass a bowel movement more easily. Diet also plays a large factor when it comes to constipation. Increasing fluid intake can help, decreasing the intake of high sugary foods or even dairy products. And of course, incorporating high fiber foods. This includes fruits that start with a P. Just remember, P is for poop, and that's what we want. So, fruits such as peaches, plums, prunes, or even pears. If the cause of encopresis is a fecal impaction, that's what we need to treat. So we can do this with enemas, lubricants, or even laxatives. An example of a laxative would be polyethylene glycol. Other nursing interventions that we need to think about or include for clients with encopresis is reinstating toileting habits. Remember, clients with secondary encopresis have already achieved toilet training and bowel control. We just need to get them back into these toileting habits. We can do that by scheduling toileting throughout the day. Typically every 2 hours, we can try to have the child go to the restroom or even schedule a toileting after each meal and before bedtime. Keeping a time log of toileting can also be helpful for you to keep track of when a bowel movement was actually passed, or even to get feedback on how often to schedule these toileting. Providing a quiet activity while going to the bathroom or toileting can also be helpful. Remember, some kids actually have fear of defecation, so this can distract them so they're not tensing up or anticipating pain with a bowel movement. Or even giving them a stool to prop their feet up on, so this elevates their knees and opens up and relaxes their abdomen and pelvic floor. Family teaching and education is so important. This takes a village for kids who are experiencing encopresis. What we really need to make sure is that we're reassuring families that this is temporary and we can get this client to reinstate their toileting habits. We want to make sure the families know to avoid punishment. These clients are already experiencing possibly some low self-esteem or guilt and embarrassment. We don't need to tack on punishment on top of that. Instilling positive reinforcement can be so helpful and encouraging to these clients. Once the child attempts to use the toilet, we can give them a reward, whether it be a sticker on the sticker chart, a star, or even a little smiley face. Although we're educating our clients and families that this is a temporary issue and will resolve, families also need to know that relapse is possible, and this can occur with any stressful life event that the child experiences. If this is the case, the families need to be prepared to implement interventions in order to restore toileting habits again.